pledge allegiance
to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
Okay. First item is public comment. Seeing no one here, we'll move on to approval of the consent agenda, which includes the regular minutes and the calendar for check signing. We've got Judy on the 8th. I'm going to just tentatively put Gerald on the 22nd. You snooze, you lose. Okay. Any motions for accepting the consent agenda?
Well, I'll make a motion to accept the consent agenda.
I will second, I'm sorry.
Been moved and seconded to approve the consent agenda as presented. All those in favor?
Aye.
Aye.
Okay, passes unanimously. Moving right on with it, the financial report. Cheryl, are you ready?
Yeah.
Okay.
Oh, I
Yeah.
okay, I have it, sorry, I forgot. What? I can't see either, sorry.
The projector is very blurry. I was trying to get it to,
Does it need to be focused?
I already tried. I'm gonna mention it to Stephen. I was standing on a chair earlier trying to do it.
Get you some binoculars.
Okay, so, patient counts. February is here. We had 305 patients in the hospital. It was a whole lot less than the 358 we had in January, but not a horrible month. It's about 10 less than our current average.
But February is a short month.
And February is a short month, that's very true. And so, year over year, we have 164 less patients. That's a decrease of 6%. A lot of that is surgery, and some of it is ED. Under ancillary services, we also had a much slower month, shorter month as well, but still these numbers are less than last month, and generally speaking, they're less than average as well. So overall, a slow month. Another thing to note is that, I don't always talk about these numbers, but our average daily census and acute swing, kind of static, but the length of stay is decreasing. Year over year, it's decreased by almost 9%. So that's not really good for generating revenue, but it does indicate that it reflects the national trend, and it reflects hopefully better profit rate. So,
That's just a reflection of the effort to get people back home.
yeah, and
In order to correlate that, you would want to look at the case mix index, so how sick people are, and see if we've seen a stasis with our case mix index. So if some patients that are not very sick versus some that are much sicker, you can rank that. If we have had it to where patients are generally not as sick, then it makes sense that our length of stay would be less. If we are keeping sicker patients and still having a shorter length of stay, that is an important change. Okay, does that make sense? So we can look at
okay. All right, so trying to expand my reporting, because I hear we could be more robust, so I've added a few things. Here, these colors are making it a little bit hard for me to see, and I suppose you too. The blue is the 4-year low. The green is the 4-year high. This is gross patient charges. Last month was 3.88 million. This month was down to 2.896 million. So quite a drop from this month to that month. Our average, new monthly average is 3.183 million, so year over year, 8% increase, so this is a fairly good number.
You can see every February it drops anyway.
It does, yeah.
We should see a
Yeah.
pop back up in March.
And I'm pretty sure we will. We haven't closed yet, so I don't know, but the census has been strong. So,
As an example, we had days where we actually had 19 patients in the house. That's that's very busy for us. And we didn't have OB during that time. So if you think about it, we have essentially 20 beds and then 4 OB beds.
okay.
Does that make sense?
Yeah.
All right. Here is collections on AR. February was $1.8 million. Our average for this year is right now at $1.88 million. The February is here in red. One of the few things I can see at this point in time, and I had to estimate the last day because I never did get it, but $2.44 million in deposits in March, so that's a much better month for cash collections. And again, I highlighted blue as the low month in these 4-year period and green as our high point. So, okay, days in AR, we hit a high point at 101. At the end of February, we were down to 93. At the end of March, we were down to 90. As of today, we're down to 82. This is something that the system will run for me, even though I can't tell you what my revenue was in March, it still can do this, so that's cool. Anyway, that is very good news. And
That should reflect then in collections this in April.
yeah, yes, it does. Among other things, yes. So this is our current high and our trend. Here we are. And hopefully by the time we get to the end of it, it'll be even less than that, but obviously I don't know. Okay. Our days cash right now are only 58 days. We have gotten, I think, all of our payments. We've got the money, but a lot of it came in March, so, which is good. We got the Medicare money, we got Medicaid money, we got the county money, we got from Jay Greer, we got the bond borrow money came through, is in here in March. However, unfortunately, we also have to make our annual bond payment in March. So that took $448,000. So I guess I'm not expecting March to rocket up. So let's see. One of the things to note that I've been looking at in regards to this number is that currently we're making payments of $65,000 against our debt, the MRI, the CT, the bonds, and of course that'll go up by 448 occasionally. But still, that starts to have an impact on cash, which we expected. We knew that was coming. And the other thing that we that Susan and I spent working on today a little bit, which I don't think I have a slide on, but we did an analysis of AR, and I have some more slides on AR and some more discussion of AR. But when we looked at that closely, we said if our days in AR were down to 60, which is kind of our goal. I mean that's a mediocre goal. It's not a high goal.
Sure.
So if our days in AR were 60, that means we would have, based on our current rate of contractuals, we would have an additional $1.2 million in the bank.
Right.
And that would have brought this days in AR number up to 73. So it would have a pretty healthy impact, but we still have some other things to solve. Okay.
Have any additional to say on that, or?
We have spent, so I came in officially the midway through
Yeah, I was gonna put her on the hot seat till
March-
next month maybe, but,
March
you know.
18th.
She's here.
But it's important to be here. I've spent this time kind of building with the team. We have a lot of changes that are going on, and we're assessing workflows and seeing where the biggest holes are first. And so we've actually made quite a bit of progress in identifying some of those weaker workflows and getting those repaired. And so we're looking forward to the next few months really being in that cleanup mode and strengthening those workflows and making sure training is where it needs to be and that they're a strong team able to communicate together and get those stronger workflows in place that will hopefully have an impact on us being able to.
So are you in the program getting along?
I'm program collecting money. But in order to collect money, you have to have a strong workflow and they have to know what they need to do. And so we need to identify that they have the tools they need to be successful.
Okay, thank you.
Yeah, and we do have a lot of tools. We're working on that. We're working with RICAN to make sure that we're doing everything we could. That's one of the tools, and if we can't do everything we want, then maybe we'll throw them out. But I think another thing that's interesting to note is we've had a couple of Dickie Figures retiring, so we're losing one there. Carrie Cornelius has gone to work at home. We've lost a few other people. Who else have we lost?
I know there'll be six
There will be six
of us that it will have started in a 30-day period. So we're definitely in a rebuilding and figuring out
Well,
exactly.
It's a learning curve, but
Yeah.
I also think it's fresh eyes, and I think it's gonna have a very rapid impact.
So is RICAN giving you some good educational tools to help you with the program?
Yes, some. There's a few challenges that always go along with that. Anytime you have interfaces between systems, it can be challenging at times. So we're figuring those out, and I have a meeting scheduled, a phone meeting with the representative from RICAN to get some more in-depth training and figure out how to use those tools better and to be more efficient with them. So we're looking to increase our use of RICAN more positively in the next month or so.
Or throw it away.
Or throw it away?
We'll see. We're gonna try and make it work.
Yeah, we will. Okay, so then this is a little bit different than what I've looked at before. This is the profit and loss for the month of February. This is actual versus budget. This is actual versus prior year. You get all of this information in your packet, but not exactly in this form. Our net revenue is $227,000 below budget. Our expenses are $72K below budget, which we're really quite a bit over in materials and services, and we're well under in salaries and benefits. Our operating gain is $150,000 below budget. We're at, loss, I should say, not gain. So $338,000 loss for the month. Then bottom line for the month was a loss of $147,000. Budgeted for $27,000, so our loss, we are $170 below budget for the month of February. All right, so then comparing this February to our past February, revenue was 2.3, last year 2 million, so more net revenue, 291,000. Expenses, total expenses were 350,000 more this year than last year, kind of across the board. The net for the month, again, was a loss of 142. Last year, we had a loss of 82, so a little bit worse than last February. And then, of course, year to date. So this is the profit and loss year to date. This is actual versus budget. This is actual versus the prior year. Our revenue our net revenue is $20,200,000, which is $480,000 less than budget. And I would have to say not a horrible thing considering the lack of orthopedic surgery. I mean, we certainly made up quite a bit of it in other areas. Our total expenses are $21,960,000. We budgeted 22, so 192,000 under budget. Kind of the killer here is the 670,000 that we're over budget in materials and services, which has much to do with our with spending a lot more than we had anticipated on moving back and forth and doing wiring, buying furniture and supplies and all those things.
So you're looking at those being one-time expenses?
Yes, yes. And then further to that, when you're looking at days cash, so that calculation is looking at your last 12 months of expenses, which are way high. So I don't want to seem like I'm making it sound less than it is, but it's unlikely that that spending level is going to continue. So that days cash is expecting, is anticipating that same high level of expenditure, and that shouldn't be true. So I hope we will see that, and we are kind of seeing it come down. We are seeing it come down. So then, our net gain for year-to-date is now at 137,000, budgeted at 219. So we're 82,000 behind our budget for the year. And again, not really too bad given some of the unforeseen hurdles that we have had to deal with. Okay, versus prior year. Our revenue is $2.1 million higher than year-to-date last year at this time. Our total expenses are $2.8 million. So that's not a good number.
Again, that's the materials and services.
A little higher than what you'd like to see. Our total loss, operating loss is 1.7. Last year was 1 million, so we're 673,000, which is very close to that number right there. Okay, so net, we have a loss of 137, or gain, I'm sorry, this is a positive number. Positive net profit year to date, 137. Last year we were at 863, so we're $726,000 behind last year at this time.
Right, last year we got a $350,000 contribution.
Yep.
So that's a anomaly as well.
Yep, true. Very true. Okay. Any questions on those?
I don't have a question on that, but I have a question. Did I see in the minutes from last meeting that we had some additional unexpected expenses in clinic, moving around and that sort of thing? Did I read that?
Not for the month.
It wasn't moving around.
We just alluded to that a minute ago.
Yeah, well, I mean, we moved down there and then we moved back.
Well, right. But that actually was to have saved the total construction cost because we were able to finish it faster, so we didn't have the overhead that they would have had and some other things related. Now, what you read about was we had some heating issues. And so we had to, and they were finishing this week, changing out pumps and some valves and making adjustments. That's what,
Okay.
it was those kinds of things. And when something is not working, you've got to fix it.
And those doors too were too narrow.
And the door.
They can put in, and it's a frustrating thing. It's my fault that I missed it, but I don't measure every door, and I don't look, when I look at the design, I really rely on the architects.
Was this the front door out here?
No, it's the front door to the
Oh.
rural health clinic.
Okay,
And
okay.
it is 36 inches, so it's not a problem getting through for most people. But our bariatric wheelchairs are 35 inches, so you smash knuckles every time you walk somebody through. And they just didn't think of that. And it's foolish not to fix it. So it's those kinds of things that you'd like to think that there aren't oversights or that people don't make mistakes, but it does occur.
That's one of those things you think that the architect should make good.
Right.
Yeah.
So code is 36 inches, but we should have been looking for 42.
So they're putting in the larger size.
Okay.
And what would have been nice is if we'd been able to leave it open, not have a door at all. but that's a common corridor. So we have to be able to close that at night and keep people from walking around. So the corridor is the adequate width. That means it's an oversight. It's those kind of things. And if we don't fix it now, we'll be fixing it later, guaranteed.
And this may be inappropriate at this point in the budget, in the meeting tonight, but how's everything over in the gardens? Are they doing okay? I mean, everything's been fixed over there and, no? We still have some maintenance to do, repairs to do?
I can talk about that later, or right now it's
Okay.
fine, but if.
No, that's fine.
So we don't forget about it. What we have is, we had some internal pipes, so not along the outside walls, so internal to the building, pipes were freezing. And the solution that they recommended was to put heat tape along those pipes to keep them from freezing. We think that that's a design error. And the architects have been trying to figure out what could be the cause of it. We added additional insulation to try and protect from freezing. Part of the design issue gets into, well, there's an expected certain amount of heat that rises from the room, getting into the attic above, that keeps the pipes from freezing. Was that a factor? Then we found out that some of our staff, thinking that they were saving, when a couple of people moved out of the rooms for whether they expired or they changed locations, staff were closing the doors and turning down the heat. Except it's geothermal heat, so you want it heated throughout. If they had left the doors open and the heat on, we might not have had that problem. So we have to look at, there's a variety of things that might have contributed to that problem. And it's easy to say, we think this, we can point fingers, but there might be, it might have been operator error, as they say. So we need to look at it carefully. And the architects are engaged in trying to help us figure out a solution. So it's those kinds of things that as we look at them, how do we find the right answer without just automatically spending a bunch of money to fix something and say, oh, now it's resolved. Because if you put heat tape on it, that has a life expectancy. Who's going to remember to go replace the heat tape when because it only lasts so long. And then you have to crawl around up in the attic. It does seem to be not an elegant solution, that's what. So,
Going on,
Going on, Cheryl?
balance sheet. Okay, so for the current month, February, cash went up a little bit, AR went up, down, patient AR went down, but so did other AR. So you see a big difference between receivables between January and February, and that is because we entered the adjusting journal entries from the auditors, and so it changed our past history. But we can't do that until the audit is done and everything is done. We could have done it a month ago, but we didn't because it can really foobar or screw up the system. I mean, doing the hard close and journal entry is kind of a big deal with CPSI, so you want to make sure you have plenty of time to fix it. So we did it early in the month.
So is that change in AR written off?
Yeah, yeah. So it's basically the intercompany receivables, the bad debt entry. It's just the intercompanies, not our patient AR at all. And then the other side of that is the fund balance. So the fund balance went 14.9 to 12.8.
Because that's prior year adjustment, isn't it? The audit adjustment would have been for,
Well, except that we don't actually close the prior year until we get the journal entries.
correct.
And so it's not really a prior year adjustment because we go back into the prior year and do it to 6/30/18 financials.
So this adjustment is a current year adjustment.
Yeah, it ends up being that way.
Okay.
Sorry. Okay, so, we also have, the last, 3 years of balance sheets up there to look at. And compared to where we ended at 6/30/18 after those journal entries were made, our cash and AR is higher, our fixed assets are higher, obviously, because we continue building, and we have more debt. And really, we've got a small increase in fund balance year over year, after all those entries were made from last year. I'm sure that's clear as mud. Okay, because the fund balance has gone up because we have a small net profit, so. I just feel like and I am, when you make that entry, you're sort of changing history, and it's confusing, and it would be really great if we could get our audit done sooner, so this wouldn't wait until practically the end of the following year before those changes are made. But I can't really control that. Okay, so here's a report that we get out of CPSI that we're sort of going backwards now. We're going to talk about AR some more. This is a report that runs, you don't have to create it, I mean, just run it. And it goes by the week. It tells you the as of date. It's as of census date, the daily revenue. So you can kind of look at your daily charges and see the average is 92. This is the trial balance, which in this case means the AR. This is our AR balance, went from 19,000 on 125 down to 9 million, not 19, 7 million on 329. It's kind of hard to see, as well as an average. And it shows our AR days and coming down to 81.7 at 329. So then we have a few different charts, coded and unchecked claims. So these are just starting into the process. And this tells you how many days they are is attributed to that and how many claims they are. So these are some of the reports that Susan and I are looking at to get a better idea of where we need to focus our attention. One good thing though is to see that the AR days in most of these categories are on a downward trend. But it also helps us, see not coded, how many days past discharge, etc. So we know, is this a billing issue? Is it a medical records issue? Is it doctors? And so we're scheming on ways to, I'm sorry, did I go back too fast? I can go backwards. You can't see it, can you?
Well, no, not very well.
Yeah. I'll put them in the report next month, so you can see it on paper in front of you.
And that would be good.
And that'll be,
You're diving into the weeds here pretty good. I understand.
yeah. And some of these reports are kind of difficult. And you have to know what day this report was run on. This is 10 weeks worth of data. This is 100 days. This is 80 days. It's just saying that your days in AR went from over this 10-week period went from 100 to 80 something. So, and mostly I'm just giving you an idea of what we're looking at and giving you some more information, so in case you want to ask questions, if you see something that you think is.
So in 10 more weeks, you should be at 60.
Absolutely, that's what I told Susan. Yeah, go for
If
it.
you follow that arrow.
We follow the trend.
It'll go out long enough, it'll be zero.
Yeah. Except some,
Except for those commercials.
sometimes those medical records not coded, they go up instead of down. So,
We wanted you to have a little bit better of an idea of how we are looking, and not just relying on incomplete information. There is a lot of data that we get, and that was really the intent. Not to spend an inordinate amount of time on it, but to help you understand the complexity and the information we get.
right, so for example, this is the detail of the hospital's AR. And there are approximately 5,400 lines on this report, and every line is a medical record number. So you might have multiple names, but they have multiple visits, multiple charges, or whatever it is, you know, on different days or whatever it is. So that's a whole lot of detail. And this is just the hospital. It doesn't include any of the clinic visits. And of course, in the clinic, you're talking 50, 60 visits a day. So it's a lot of data. And unfortunately, nobody really has a super way of helping us parse through this data to figure out what we need to know. And we've kind of gotten back down to the very basics of, we take the AR in the detail and we start looking at it line by line, and we pick one and we figure out what's, you know, why isn't it paid? I mean, at this rate, it could take forever, but, you know, we realize if we identify the issues and the problems and we start fixing them, then it should just snowball on us, theoretically.
Now, are all these claims electronically submitted?
Yeah,
Not all.
but nearly all.
Most of them are, yeah, we have a few that are sent out hard copy, but for the most part, and the ones that aren't, we're looking into having them set up to go out electronically.
And how quickly do you get the response?
Depends on the payer. Medicare is probably the best at responding, and if you have a good, clean claim, you get an answer in 15 to 20 days.
Payment.
Or payment, yeah, I mean, we see whatever the response is going to be initially. But if you look at, say, Blue Cross, they're closer to 60 days, and Medicaid is somewhere in the middle.
If you got a problem, you gotta start all over.
They do, it seems like what I'm seeing so far is they'll pay certain lines. So they might pay all but a portion of, and then you have to correct and resubmit for, you know, these 3 lines upon your claim. So you usually get something. They don't usually hold everything until the claim is perfect.
That's a lot of detail.
Oh, yeah.
Mm-hmm.
That's where you're supposed to rely on the computer to help you parse that stuff out.
You are. You are. And then to add to that complexity, you have a primary payer and many times a secondary payer. So you've got to go through it again with a different insurance company after the first one is done. So.
Some of the secondaries actually get automatically billed through the primary, right?
I don't think so.
It seems like there's a little bit of that with Medicare.
Yeah.
So far as what I'm seeing is that there is some
Like
of
if you have
that, because Medicare knows that there's a secondary, so they'll go
Right.
ahead and forward it, but I wouldn't say that it's predominantly that way, but I have seen some of them have that relationship.
So, okay, so then another thing that we look at is receipts and where are receipts coming from. And so, just so you know, every month, and this is just 4 months of reports that I kind of pulled out to put in here. And actually, I have a day-by-day detail behind each of these, and this is how we monitor our receipts. And we've got it by Medicare, Medicaid, Blue Cross, commercial, all other commercial, private pay. And then we have a column for deposits for Lakeview Gardens, and a column for non-AR, and a column for bad debt recovery. But it is kind of interesting when you look at the percent of our total deposits for the month that are attributed to each of these categories. And you know, they're somewhat static, but not entirely. Wow, that was cool. What was I going to say? This has an impact on our days in AR because when we make a Medicare's pretty static, but Medicare's contractuals are a lot higher, so it's going to have an impact on lost my train of thought now, sorry. On the, what? I know, it distracted me. Okay, so another thing that we have not talked about very much at all is the fact that, we've got 3 different systems. We got Credible, we got eClinicalWorks, and we've got CPSI. We always mostly talk about CPSI because it's 90% of our ARs is CPSI, it's hospital. clinics, so this is a report that we pulled out of eClinical Works for today. Their days in AR is actually at 74. Oh, well, so sorry about that. Anyway, 74. And it's been up and down, but right now it's, I mean, a year ago it was, yeah, it was huge. So,
Part of that was because we were switching the clinic. We had been doing billing in eClinical, and we said it wasn't working well, so we started billing it through eClinical, or through CPSF.
and we've got Goose Lake in here, and we were thinking
That's just like
clinic. Yeah, okay.
It is just clinic here. Another part of that was the clinic billers. There was some, clinic billing is very different than hospital billing. And that was a pretty big learning curve, I think, in the last year for those billers. And so that is another place that we've had a change in the last month, is that Barb, who was doing our Medicare billing for the clinic, her husband took a job out of town, and so we're also gonna transition in that category as well, but we've got some strong people that are coming into that understand how the clinical portion of it works and what impact that has on the claims. So we're optimistic that that'll continue to be stable.
So, future, we'll start reporting more on those other AR,
Metrics.
yeah, so, okay. Okay, so that's it for hospital. Any questions? Okay, so we have a proposal that it would make life much less confusing for us if we changed the terms of the budget advisory committees from being a January to December period to a July to June period.
I have no
So-
problem with that.
Okay,
No, I don't either.
Do you need a vote? You probably don't. To allow us to change that. The OAR.
The OAR's just
Don't
stated
speak
that
to
it's a 3-year term. It doesn't state if it has to be calendar or fiscal, so.
If you're okay with us just moving ahead, because there wasn't a dictate that we have to have a vote, then we just go ahead and make those changes. Great, thank you.
It really makes sense. It coincides with our fiscal year.
Yeah,
it does,
Yeah.
right.
Okay.
Oh, I'm sorry. Okay, and one thing also that I forgot to mention that I just wanted to let you know that, is that, as we've been going through the budget this year, I believe that it would be wise for us to, reconsider consolidating some of our banking relationships so that, the more money you keep in a bank, the less fees you're gonna pay. Right now, we're paying a lot of fees. So if we consolidated, we could save $20,000, $30,000 a year.
Well, I have no problem with that.
Okay, so I'm gonna be working on that. I'll let you know. Okay,
That's quite a big savings.
yeah, it is, it's a lot of money, it's a lot of money.
Historically, we've talked about putting money in a variety of different banks as good neighbors. As the banks have become less local and less regional and becoming now bigger banks, the value, excuse me, the value of putting money in different banks to support our community has become less.
It would seem to me that our bank that holds our mortgage is probably the best one we want to support.
Right. Yes.
But just wanted to make sure that we were comfortable with the concept. Thank you.
All right, now Lakeview Gardens. Okay, so for Lakeview Gardens, long-term care had about 16 patients in February, and the ALF had about 11 patients for the month. They did max out sometime early in that month and have stayed there.
The assisted
I
living
meant,
is full.
did I say that wrong? Sorry,
Lakeview Gardens
as wrong.
has.
Assisted living was full.
Well,
Yes,
with-
and we have a 7-person waiting list.
So does that mean there are 12 people in there?
Right.
12 bodies are in the assisted living, and there are 7 people waiting for someone to be found.
They probably prefer to use the term bodies.
Individuals.
Okay.
Somebody used that term, butts in beds, I don't know where they came from, but something like that.
Okay,
Residents.
Residents, absolutely.
sorry.
Now you're back at the beginning.
Oh, okay. I'm sorry. What's wrong with me today? I've done this
Give her the
before.
Say, maybe someone needs to try.
I've done this before.
You normally use the space bar to advance because you couldn't get that to work last time.
All right, okay, so, our revenue for the month was $135,000. Really, I did the math, the difference between those is, really has a lot to do with being 3 less days of all those people, so it was not so bad. Still, our revenue is lower than it's been in prior years. And of course, that has a lot to do with the fact that you don't charge as much for the outpatients as you do for long-term care, and we're lower on long-term care patients. So, income statement for the month, here's February. Net revenue is 162. Wages and contract labor were down quite a bit for this month, so it had a rather large positive impact. Bottom line was a loss of $69,000. If we could be there every month, that would be a very good situation. Bring us very close to what we budgeted for it to be and what we feel like we can afford. Balance sheet. We keep the bank account low, so the fact that there's no cash just means we put the money back. We reduce the debt that Lakeview Gardens has to the hospital, so we keep their balance low, but we put the money in our account, so there's their amount due. And I guess the good news really is that they're able to, pay that down, so. Anyway. In spite of the fact that they lose me. Okay, questions on Lakeview Gardens? Medical supply, they went back to having, we're done paying the consultant, so they had a profit for the month of $9,000. And we also keep their bank account low so that they pay down their debt to the district. Okay. You can have that thing now.
Thank you.
Here's the check.
Okay. Any questions? Okay. Bruce is not here. Nursing report?
Before we jump into our, we do have a, I'd like to ask
Not on my list.
You have the
Corey?
new one? I have the new one. You're looking at the old one.
I'm looking at the old one. I'm sorry.
Corey Conley, who is our quality coordinator. Thanks. When I'm doing fine, I can speak clearly. Asked her to come and talk a little bit about a couple of items that we are working on and that she's helping us work. So Corey,
Thank you. I'm sorry I missed you.
Okay. So I'm going to talk about 2 dashboards today and that I've worked on since the past 2 quarters. So the first one is this one with everyone.
ED transfer?
Yes. So this is the ED transfer communication, and this tells us how well we are communicating with the facility we are transferring our patients to. And the information is divided into 7 categories. So basically how well we transfer our administrative communication, that is the nurse-to-nurse communication and physician-to-physician communication. So this should happen before the patient leaves the emergency department, and since the last 2 quarters it has been 100%. And the second one is patient information. So like the patient's name, address,
and their basic information should be transferred within 60 minutes of the patient's departure from the emergency department, and we have always been 100% at this. Third one is transferring the vital signs within 60 minutes again, and again we are 100%. Fourth is medication information within 60 minutes of the patient's departure, and we have been 100% here again. Fifth is physician-generated information, that is the patient's history, physical, and the reason for transfer, and if we have a plan of care. And so we were struggling with this measure because usually our physicians don't document. Usually they just talk over the phone, and every time when we report something, there has to be a document which says that the communication has taken place. So we have done better, not 100%, but still we are meeting the benchmark. Sixth is nurse-generated information. So whatever information a nurse would give the nurse of the transferring facility. So we are again meeting the benchmark. And seventh one is if there was a test performed and its result, and again we are 100%. So the total compliance tells us how many patients had their complete information transferred within the given time, and we have been meeting the benchmark since the last 2 quarters.
Where does this report go from here?
So this is a part of MBQuip, which is a CMS program which is specifically for critical access hospitals.
Okay, so they go in and they see the percentage, but they don't see the number of patients. So for example, where N equals 11, one patient is 9%.
Yeah.
I mean, that's a huge number.
But since this is just for critical access hospital, even the benchmarks are for critical access hospitals.
Okay. Okay, thank you.
The second dashboard is partnership for patient, and even this is for CMS. This is a program that CMS has created to help us track and measure how well we are doing with both our hospital-based and community-based care. So the first one is excessive anticoagulation. So the numerator here is our inpatients who suffered anticoagulation, and the denominator is inpatients who were on warfarin therapy for anticoagulation. So usually we don't have patients who have experienced anticoagulation, other than we had one in October and one in November. And so CMS has not given us any benchmarks for this. So usually we try to keep it at 0%. That's our facility goal. The second one is hypoglycemia. Again, the numerator is patients who experienced hypoglycemia, and the denominator is all the patients who received insulin during their hospital stay. And we have never had a case of hypoglycemia. The third one is adverse drug event due to opioid. So here the denominator is all the patients who have received an opioid agent, and the numerator is patients who were given naloxone to treat their opioid overdose. So here the patient in denominators are not just our hospital patient, they are even the patients who come to the ED. So we have never had a case of overdose for our patients in the hospital. So the numbers that you see, 1 in March and 2 in January, are the patients who overdosed outside and then came into the ED, and then we gave them naloxone, and we still have to report it because CMS wants us to care for the entire community. Fourth is influenza vaccine rate. So our flu period is from October to March. Last flu season we were at 76%, and our goal was to at least reach the state benchmark, which is 85%, and we have been doing great, and we were above the benchmark this flu season. Pneumonia vaccine rates, we've always been above the benchmark of 85%. Fall rates, so the numerator is number of falls and the denominator is occupied bed days. So we usually don't have a lot of falls, and this is the state benchmark, so this is not just the critical access hospital benchmark, it's all the hospitals in the state. So even though we just had maximum of 4 falls, we still are not doing great according to the state benchmark. I couldn't find the critical access benchmark. I am sure it's much higher than the state.
Of the falls, how many would you say are from swing bed patients versus acute patients?
I think most of them are acute, and so out of these 3-4 falls, none of them had major injuries. And most of them were assisted falls, but we still have to report them.
Can you explain what an assisted fall is?
So when there's a nurse present and the patient is trying to get up but still cannot properly get up and wants to sit down, so that's an assisted fall because there was a caregiver present and it happened in the presence of a caregiver and the caregiver assisted them towards the floor. So that's an assisted fall.
Everybody understand?
So this doesn't delineate if it was an assisted fall or.
Yeah, I can break it down, but since we have to report all the falls, whether it was assisted or when the patient was alone, it still counts against us. So 7th one is readmission within 30 days. So the numerator is patients who return to the hospital within 30 days of discharge, and the denominator is all the patients discharged in that month. And we're doing pretty great with this measure. So if you look at this sheet, so this is a report I received from CMS. So CMS pulls this data from the claims, and so this was for the time period July 2017 to June 2018, and it just shows how we compare to other critical access hospitals in the state, and our readmission rate is the lowest. We are the orange one on the top. Pretty awesome. Yeah, it is.
It's pretty impressive.
Yes, it is. Orange is lab.
It's not the new black.
So the next 4 measures are OB measures. First one is early elective deliveries. We have never had a early elective delivery. The 9th one is OB trauma for vaginal deliveries with instrument. So the numerator here is patients who suffered 3rd and 4th degree trauma during delivery, and the denominator is all the vaginal deliveries they were instrument assisted deliveries. So we usually are low, but we had 1 case in Feb and 1 in December. And even though in February just 1 of the delivery was instrument assisted, we are still 100%. The 10th one is vaginal deliveries without instrument. So the one before was with instrument. And again, the numerator is patients who suffer 3rd and 4th degree trauma. And we don't have cases that suffered trauma other than 1 in September. So we are doing much better when we don't use instruments for delivery. The last one is massive blood transfusion, and we have not had a case where a person received more than 4 units of packed red blood cells. That's all I have. Any questions?
Any questions?
Thank you.
Oh, thank you.
Thank you.
Appreciate that. I like the orange. Okay. Now, medical staff privilege.
Dr. Hussey. Actually, Dr. Foster is covering for him in the emergency room. I'm not sure why Dr. Hussey couldn't be here tonight. But in the fact that he's not here, we have two applicants, Frank Magner for original appointment and Damon Toscano as a consultant. He's in radiology, and Dr. Magner is family practice and covering their emergency department. The medical staff made a recommendation to you that you approve these applications, and I would do that on their behalf.
I saw one.
Moved and seconded to approve the medical staff privileging as presented. All those in favor?
Aye.
Passes unanimously. Employee recognition.
Always a good time to remind us how the staff that we have really make a difference. We have lots of really great people. This month, in light of some recent changes, as you've heard, we've had a number of changes in personnel. When that happens, that means people that are in the department have to really pull together and make a difference. And it's exceptional when the team pulls together and covers for when someone leaves. And this month, I'd like to recognize two individuals that have been really stepping up to the plate. And that's Holly Fairborn and Lacey Cleveland in our HR department. They've really done well. I'm functioning as an HR director as well as other things, and they've really made my life a little easier. So, and they've really helped bring on staff with issues as we go.
Good.
Holly and Lacey.
Good. If you'd like to leave, we won't make you sit and be tortured.
Everybody else gets tortured.
Thank you.
Thank you. I appreciate you coming. Okay, so it's the CEO report time.
This has not been a slow month it may have been a little bit harder on some of the financial things, but otherwise, we all stayed fairly busy. We've had a couple things happening that are interesting. We actually had Senator White come here, and that he didn't just come for a town hall, he actually spent a fair amount of time walking up and down the halls talking to staff. You'd think he was up for election. He was excellent. Really enjoyed. I thought he was going to be here for like 5 minutes, and he stayed almost 40 minutes. So that was a good thing. He talked to a lot of people, saw lots of issues, spoke very positively, not just about what we're doing in Lake County, but also, of course, the bills that he's working on with Senator Grassley. So we'll see where that goes. But that was the first time he's ever been to the hospital, specifically spent time. I also went with Ken Kestner on Saturday the Saturday the 16th of March, and we talked about, the intent was to talk about broadband. We ended up talking more about the needs of Southern Oregon and Eastern Oregon for staffing and for other issues, of which Senator White is very interested in. But it was well worth our presence there, and hearing what he has to say. One of the things that Corey is working on is not just looking at our data, but trying to analyze the data. And we're using two sets of analytic tools. Some of it comes from our CPSI software, the clinical not so much. So what we've actually been using are two programs. One is called Arcadia, and the other is called Lightbeam. So Arcadia is a program that was paid for predominantly by EOCCO, and they have provided that to all 10 hospitals to look at clinic data. We bought we paid additionally to have Arcadia work on all of our patients, not just the Medicaid population. And what it's trying to do is to sort through the data and identify either holes in our information or better ways to manage those patients. Lightning does the same kind of thing, only it is part of our Caravan ACO, which is the Medicare component, where we look at where our Medicare recipients are going within and how they're receiving care. So both programs are really critical to start not just looking at what's happening, but then start doing predictive modeling. One of the metrics that we have to identify, as an example, is diabetic patients. And we have to prove that we are monitoring those patients and controlling those patients that have uncontrolled diabetes. How do we do that? If we ask the doctors, how many patients do you have that are diabetics? Most can't tell you. When we use our software, we can identify the number of patients based on their lab work who's a diabetic. And then we can look at the results and look at who has uncontrolled diabetes. And then we can start predicting when, or find out when they were in last, and then contact them and say you need to be in to have this checked up on a regular basis. So we're able to look for problems that patients might have, give that information to the physician and to their support staff, and then aggressively approach the patients to try and get them to come in and get care that they need.
Does the hospital approach them, or does the physician approach them?
It's a combination. Generally speaking, the medical assistants are the ones that make the calls to the patient to get them to be in front of their clinician. So it isn't the clinicians that are calling, it's the medical assistants to try and get them to get in. That's a big challenge. So one of the things we do, for example, in our clinic is to reward medical assistants for helping us meet those metrics. Because last year we got, $160,000 from the CCO that helped pay for our services. But because they put in the efforts to help us, now we're giving them the tools to identify what patients to call, but they're calling and badgering and encouraging, not badgering, but encouraging patients to come in and get the care that
Reminding.
Pardon me?
Reminding, helping to partner in their care.
Isn't that part of your job, Charles?
It is part of their job, and that's what we hire them to, and not only assist the doctor when they're taking care of the patients in the room, but also to get them in and identifying opportunities to help them manage their care. And sometimes it's, sometimes the patients wish they would come in, but life goes on and they miss their appointments. How do we encourage them to come in and provide them the incentives and tools to be present so they can get the care? All of that is driven by if we can provide that preventative care sooner, the total cost of care will be less. So when we see our numbers in our emergency room go down, that's in large part, it's economically not as strong for us as a hospital, but it's a sign that we're delivering far more appropriate care in the clinic with our walk-in service or our ready care, that we're catching patients that are going to the emergency room before and redirecting them. So we're doing a lot of things to really help the patient get the care in the most appropriate place.
Is there a program similar to like what our dentist does? Sends a card 3 months early. You're going to have an appointment.
There,
Calls a week early and then calls every night for 10 days.
getting text messages and all that, yes.
Right.
No, I'm serious. I mean, for say a known diabetic, shouldn't they have a regular
Follow up.
They should.
need metric? I mean, you just automatically send them and they should either,
One of the reasons why we look, amongst many reasons, that we look at changing or refocusing our energy on our software. When we look at Cerner, Epic,
Well,
full CPS.
What about through the patient portal? Couldn't you send an email, for example, to a patient and say it's time for your diabetic visit?
So one of the things we want to do, that is an opportunity, but most people don't access the portal on a regular basis. Sometimes we have to call, sometimes we text, sometimes we mail, sometimes we try. We can't send carrier pigeons that don't work, but we try to find what works for a person. And it's a constant battle, as Susan can easily and readily describe. So there are programs, each one of the software companies that we've talked to all have better reminder processes than what we're currently using. So when we make that recommendation to you, to whatever we're going to do on the EMR system, all of them have a much more robust notification like the dentists use. They're very good at it. I mean, to keep it in mind though, when you look at our CCO population, there are 1,800 people in this Lake County that are in the CCO. We care for about 1,200. The others are cared for either with Dr. Grant's clinic or with Northwood. Okay? So out of the Pine Clinic. Of the patients that are seen in Lake County, that are a recipient of the Medicaid program through the CCO, 75% get care someplace within our system. They may go to a doctor, they may go to the emergency room, they may have an outpatient test. 75%. 25% don't. In the dental portion, it's the opposite. 25% get care, 75% don't. So no, why is that important? Because with 65% of the population in the United States having diabetes or pre-diabetic,
Is that really?
65%?
65
Oh,
is right.
okay.
This is on the epidemic level. What do
Why
we do?
is that? Is it obesity?
We all consume way too much sugar. And obesity is a cause of eating too much sugar. And you can go on and on and on. But by and large, our society consumes far more sugar than our bodies are really able to process. So how do we deal with that in Lake County? Those are the kind of things that we have an obligation, not as a hospital, but as a health district, to focus on. And it's consuming more and more of our time as we look at this. And Arcadia and Lightbeam software are programs that help us look at it. That was the purpose of my description.
So Charlie, back to one of your earlier comments about asking the physicians how many diabetic patients they have, and they can't answer that. Do you think it's 65%?
I don't know. Off the top of my head, I can't tell you. But
Wow.
there are many people that are diabetic that, with weight loss, can control their diabetes without taking insulin. One of the best proven methods for reducing diabetes in the obese is to have stomach stapling or stomach restricting. That's surgery. It's very expensive, but it saves lives. And diabetes is a horrible condition, horrible disease. So the bigger part about why the physicians may not know how many they have is because they treat one patient at a time. They don't think about the population of the people within their that are assigned to them or that have chosen as their practitioner. Some may go to their doctor every week or month. Others may not go but once a year or every couple of years because they feel they're perfectly fine. And that physician isn't focused on that person's care. They're worried about the people that are coming in. And that's why they may not be thinking about it, but as a system we have to. Okay?
Where we have the clinical system for our doctors, don't we have access to go run a search and find out how many people have diabetes?
We do, we do. And sometimes we rely on people like Lori to work on gathering that. Sometimes various carriers encourage us by giving us information. Because you could be hunting for issues all day long. And then the next part is doing something about it. It's one thing to know.
Right.
How do you get after fixing it? So we want to spend as much time as we can focusing on doing something about it, not so much always studying. And we look for it in any way we can. And we want to have our computer systems do most of the labor.
Right.
So that's part of our. Moving on, the ambulance building. I gave notice to our engineer saying that we need to have a plan so that we could have cost estimates to the board no later than May. Because I have still no plans. I'm frustrated with that. We're moving forward. We will have our O&A negotiations that just happen to be occurring at the time of our first budget meeting. So it'll make for a busy day. We'll negotiate in the morning and have the budget meeting in the evening and then finish up the day after. Hopefully the budget will be approved that first night and we'll be able to proceed. I had hoped that we could go through the negotiations prior to the budget meeting so that we could have the results of the negotiations able to put into our budget. Unfortunately, that negotiation didn't go the way we were hoping. So,
It's not worth moving the budget meeting.
we have some legislative required dates that we have to do. And it's hard enough to get that vital committee to meet at that date. So we just, that's the nature of it. We were very, it was pretty exciting to have on Monday and Tuesday a visit by the Oregon Health Policy Board. We think that we're able to be here. It's a pretty big deal for this group to come out here and spend the amount of time that they did. And
They brought the rain.
they did. And to many of the things we have much to be appreciative of. Because Portlandians bringing us rain is a great thing. We had several people making presentations, and there's a tour on how in Lakeview we are integrating and working together as a team to try to improve the health of our population. And those of you that look at the Herald and News may have seen that they announced in their paper this last couple of days that unfortunately Klamath Falls ranks by Robert Wood Johnson, the national evaluation company that looks at the health of every county in every state in the union. Klamath Falls continues to score the worst in the state of Oregon. Now, from a Lake County standpoint, we were second for many years. We are now up to number 29, so we are not at the 36th spot. Making headway. A large part of that is our small population. So we can't own that as a mark of how we're just all sick. But
Out of what span? What's included in that?
there are multiple indicators that
I mean,
the population.
all the U.S. or just the state of Oregon, or what are we
This is
talking?
in the state of Oregon.
So what Robert Wood Johnson does is it evaluates health metrics for the entire population and sorts it by county. So all of the United States. And they'll look at, for example, what percentage of the population smokes. And they can identify by what people say, how many people is in Lake County versus the state of Oregon. And that's how they rank each county as how healthy they are. The larger counties, which have much larger populations of younger people, always score best. If you look at the healthiest county in the United States, it's in Boulder, Colorado. Huge population of younger, very active people. Where I think they have smoking cordons all around to keep any smokers out, except for pot. That's my opinion. But that's not considered a health condition that they need to. So when we look at, we had a visit by St. Charles representatives to talk about some of the issues that we have, relationship, how does it work. We talked often to you about how we differ with their principal referral sources have been, or community-wise, has been Lake Harney, or Burns, John Day. They now include Klamath Falls. Part of that is because in Klamath Falls, they do not have any longer neurosurgery. So a lot of their business for neurosurgery goes up to Penn. What they're able, with their new Epic system, able to do is identify about how much money, in terms of revenue, going to the St. Charles system. Does Lake County impact? St. Charles system is about a $900 million business. We as a county represent about $20 million a year in referrals to that organization. If you take Klamath, Lake, Burns, or Harney, and John Day Grant.
All of Grant or just John Day?
Predominantly John Day. You know, on the north end of the county, they're more prone to go to Hamilton. Some people go to Baker City, but generally speaking, the referral patterns from John Day are to Penn. Harney County, they bifurcate. Some go to Boise, some go to Penn. They're about equidistant. The total for the four communities represents about $80 million. So about 10% of St. Charles system comes from the surrounding areas. They don't track as much that comes from the north, from Hood River in the south, or mid-Columbia. More the referral patterns, it's easier to drive the 84 to get the point.
So the 20 million that we spend them, how much is something that we could do here if we worked at it?
That's the next challenge to figure out, and what is appropriate. Sometimes we're never going to be able to go. The patient has a heart attack and needs to have intervention by, or heart condition, intervention by an invasive cardiologist. We'll never do that. If they go for certain kinds of technologies, radiation therapy, some things we'll never do. But that's opportunity for us to look at.
I'm sure your surgery is part of that.
So, moving on to that, we have signed a contract with an orthopedic surgeon. His name is Walker Minku. We are working on him being here this month, if at all possible. He's what's going to be called a temporary to permanent possibility. So he would start off as temporary, and if he likes it here, and we like it here, if he likes us and we like him, then we would engage into a permanent relocation. He comes from South Dakota. The only part we're waiting on right now is his getting an Oregon license.
So what's his specialty?
He's an orthopedic surgeon.
Oh.
Coming from South Dakota? Okay.
And what's his history as far as types of surgery?
He has migrated to hands, partly because he finds that very interesting. He's done all sorts of orthopedic cases over this. He thinks he has 7 to 10 years more of active clinical practice. So over the 20 to 30 years that he's been practicing, he's done all different kinds of things.
Hips and knees,
All different kinds
shoulders,
of
and all that.
Yes. He's what is often called a bread-and-butter orthopedic surgeon, but has an interest in hands.
So when's he gonna be here, Charlie?
Well, we originally had him coming in the middle of this month, but that's all predicated on his getting his license.
We're waiting on the Oregon Medical Board to finalize his application and issue his license, so. I've called, I've asked, I've said please, we're hoping that they'll push it faster.
He's interested, we're interested. And it was, when you asked how many could we capture that are otherwise, I saw a report just a little bit ago that said just in the last quarter we shipped out by transportation, predominantly air, at least 5 or 6 hips that we could have done here, plus other kinds of procedures. And that's just the emergency, that's not the elective.
Is this a full-time position he's coming for?
Good. So we're excited about that. We got another physician here today. His name is Dr. Guriaria, if I say his name correctly. He's a cardiologist. He was on the faculty at OHSU, but practicing in Mid-Columbia. Mid-Columbia in the Dalles had done a very unique, established a relationship about 6-8 years ago with OHSU. And so he had practiced, even though he was on the faculty at OHSU, he was working predominantly in the Mid-Columbia down in the Dalles area, Mid-Columbia Hospital in the Dalles, where they grew that referral pattern in business from having virtually none to having multiple cardiologists, and they became kind of a hub for Washingtonians across the river, as well as people all from Morrow County, northern Deschutes County. So they really did a good job. So we're hopeful that this will be a positive relationship. We've been working on this for years. Dr. Young, Eddie Young, had been coming to Lakeview, but because of his health reasons, has not been able to travel. So this will be, and we hope, we expect that he will be coming on a consistent basis, which had been one of the problems. Last but not least, we anticipated this, and now we have a much better idea. When we started the clinic remodeling, we approached Dr. Graham about making any changes to his office as part of the project. He chose at that time and said, no, everything is perfectly fine. Now that he has seen how it looks on the remodel part, we will begin remodeling his office. That will start, it is starting now, and it will be completed, we estimate, within a month and a half or so.
What did that do to our budget?
It'll be about $15,000.
So
In supplies, not including, we'll save a lot of money because we'll be doing it ourselves. So
What do you do for $15,000?
we'll be painting, putting in all the carpeting, putting in new vinyl in the rooms, sprucing it up.
No
So
structural changes?
It's not going to be structural changes. So it's not, but everyone wants, when it's, everyone else looks nice, you'd like to have it.
You'll
And
get a
frankly,
fresh paint smell.
Does he have geothermal over there?
no, he has, we have in fact replaced all of his heating and air conditioning, and with much more current units. So everybody has been brought up. We also changed all the windows, if you recall. One of the issues was, do we want to just change the windows on the new side, or do we want to do the whole thing? And we said it's foolish not to put in the more energy efficient windows and have a consistent look through. So we changed the siding and the external. That concludes my comments.
Any other issues from the board? No? Okay. We'll go into executive session then. Under ORS 192, 660, Bracket 2, Bracket A personnel. C medical staff, or H legal.